Okay, good afternoon, everyone. I think we will get started. Thank you for joining us for this month's Teach Educational Round. Here with us, we have Dr. Alice Ordean, who will be presenting an approach to treating women with alcohol and tobacco use disorders during pregnancy and lactation. But before I hand it off to our presenter, I'm just going to go over a few housekeeping rules as per usual. So first of all, if you're interested in obtaining a letter of completion for this month's Teach Educational Round, please make sure that you have registered for this webinar and completed the pre-learning assessment. You have signed in to view this webinar using your first and last name. And finally, you complete the evaluation and post-learning assessment, which will be emailed to you this afternoon, and you'll have 1 week to complete it. These webinars are being live tweeted on Twitter, and you can follow us at PSQuitSmoking or use the hashtag TeachWebinar to post or read questions. Here's a biography of our faculty presenter, Dr. Alice Ordean. Dr. Ordean is the Medical Director of the Toronto Centre for Substance Use and Pregnancy at St. Joseph's Healthcare Centre and is an Assistant Professor in the Department of Family and Community Medicine at the University of Toronto. She is one of the few physicians in Ontario with expertise in perinatal addiction medicine. Dr. Ordean has been a principal investigator in numerous research projects, including the development of educational tools for healthcare providers and guidelines relating to substance use in pregnancy. Welcome. Here are a list of her disclosures, as well as our disclosures. And remember, the content of the Teach Educational Rounds are primarily based on evidence-based guidelines from the following sources. These materials, as well as any presentation and discussion, set out only general principles, and they do not replace the need for individualized clinical treatment plans by healthcare providers. And before I hand it off to our presenter, I'm just going to do a few polling questions to gauge who has joined us here today. So in a minute, using your computer, could you please indicate which of the following organizations you work for? And if your organization isn't here, please feel free to type it in the chat box. So I'm seeing some public health units pop up here, family health teams, addiction agencies, okay. And some others, feel free to type those in the chat box. YMCA, great. Okay, and again, could you please indicate what your current discipline is? And you may need to scroll down to see all the options here. Addiction counselors, health promoters, registered nurses, social workers, psychotherapists. We have a few people typing. Lactation consultant, great. And finally, could you please indicate which region your organization primarily serves? So a lot are popping up in Central East area, Toronto and Greater area, out of province, great, Alberta, Quebec, Newfoundland, Manitoba, great. Okay, so with that, I will leave it to our presenter to take it away. Thank you so much, everyone, and enjoy.
So good afternoon, everyone, and thanks for joining me for my presentation on tobacco and alcohol use disorders during pregnancy and lactation. My learning objectives for this presentation are to describe the prevalence of alcohol and tobacco use during pregnancy and lactation, identify the effects or the impacts of alcohol and tobacco use during these time periods, and to discuss recommendations for managing alcohol and tobacco use in pregnancy and lactation and leave you with an overall approach. I've put together 2 case scenarios from a variety of clients that I've seen just to highlight some of the differences or the nuances in some of the clients that may come to your office. So the first scenario is a 28-year-old female. It's her first pregnancy who comes in for a pregnancy discussion. When she's asked about her lifestyle, she reports smoking 5 to 7 cigarettes for the past 3 years, and she's asking for advice regarding her smoking and how it will affect her baby. So how would you respond to her? How would you advise her? What interventions would you offer her, and what smoking cessation medications would you even consider? So contrast someone like her with another client who's a 31-year-old female. G3P1 means it's a third pregnancy. She already has a child. Let's say she has maybe a preschool child. She reports smoking 1 pack a day for 15 years. Also reports binge drinking on weekends. She's not sure if she can quit smoking, and she hasn't even thought about quitting drinking. How would you advise someone like her? What interventions would you offer her? And what are the differences in two cases? So I wanted to highlight the first case, which implies maybe someone who's more likely to be easily quitting, someone who's easily able to quit. And the second scenario is maybe somebody who has more dependence issues, who may need more brief interventions and more counseling. So my goal during the presentation is to provide you with some of the skills to address these issues. So what is the prevalence of alcohol and tobacco use among Canadian women? I always find this interesting. Despite numerous public health campaigns, the prevalence of alcohol and tobacco use remains very high in pregnancy and lactation. So we have data from several sources. One of them is the Canadian Tobacco, Alcohol, and Drug Use Survey, which looked at past 12 months use by women, and they found that 77% of women reported drinking in the past 12 months, 13.5% reporting using tobacco products. When we look at data, and that's from 2017, so more recent information, when we contrast this with the Canadian Maternity Experiences Survey, which is a bit of an older survey, which looked at prevalence rates during pregnancy. So they looked at 3 months before the pregnancy and what happens once women were aware they were pregnant. So they found that 62% of the women they had surveyed reported drinking, and that decreased to 10.5% once they were aware of the pregnancy and during the pregnancy itself. Similarly, with tobacco use, 22% had reported using cigarette smoking, and that reduced to 10.5%. Now, during lactation, so postpartum, you can see that with both alcohol and tobacco, there was a resumption of use. So when we look at alcohol use, about twice as many women started drinking postpartum, and when we look at tobacco use, 47% of those who actually were able to quit during pregnancy started smoking again in the postpartum period. What about some other data? So this is actually a study from the U.S., which some of you might have heard about. It's called the National Survey on Drug Use and Health. It actually gives us good comparison data. So this is one of the charts they've produced, and it gives you wealth of information. So when we look at comparing our data from Canada to the U.S., we can see that when in the second column there under pregnancy, when we look at tobacco products in 2017, 14.7% were using tobacco products, specifically 13.8% cigarettes. And actually that's something I want to highlight. I use the word tobacco and cigarette smoking maybe interchangeably because as you can see, most of the tobacco use in the North America is really usually referring to cigarette smoking. When we look at alcohol use rates, 11.5% of pregnant women were reporting drinking in their pregnancy. So very similar numbers to what we had from about a decade ago in Canada. And this is, again, recent data in the U.S. What about the extent of alcohol use? When we look at the severity of alcohol use, we have data from the U.S. also on the binge alcohol use in pregnancy. And their numbers are 5% of pregnant women reporting binge drinking. So that's a significant proportion of women who are pregnant continuing to drink at higher levels. The definition of binge alcohol use in this study was any woman who drank 4 or more drinks per occasion. And then the second category of heavy alcohol use was defined having those binge episodes at least on 5 days out of the past 30. When we look at the bottom row there, tobacco products or alcohol use, we have 22% of pregnant women in 2017 reporting either or, which means that there's an overlap, so implying this concurrent use of products between tobacco and alcohol use. The prevalence of problematic use in Canada, we have some data looking at cigarette smoking predominantly, not as much at alcohol, and depends how we define problematic use. So one of the criteria we can look at is the daily smoking rates. So this is data again from the Canadian Maternity Experiences Survey, and they found that of those who were smoking, 7% were smoking daily during pregnancy, about half were smoking more than 10 cigarettes a day, and the mean was roughly about 12 cigarettes daily. Nicotine dependence was reported by the first survey, the Canadian Tobacco, Alcohol, and Drug Use Survey. They found that 20% of smokers were having their first cigarette within 5 minutes of waking up, showing a very high nicotine dependence, and 28% had their cigarettes at 6 to 30 minutes. Interestingly, there's also correlations coming up that those who were smoking during pregnancy were also most likely drinking during their pregnancy. So here is that hint of concurrent substance exposures. So the NSDUH decided to also look beyond just the prevalence rates, but to look at various characteristics that may be associated with the use of alcohol in pregnancy. And this may look like a busy slide, but I'll talk you through what the data is showing. So across the top, we have past month alcohol use, past month binge alcohol use, and past months heavy alcohol use. Going down the columns, we have the different criteria, so age groups, poverty levels, the type of health insurance in the U.S., and then trimester of pregnancy. So this may not be very surprising, but if we look at the data for past month binge alcohol use, so for pregnant women, we see that this was more prevalent among women who were between the ages of 18 to 25. This is very similar to Canadian data. In the U.S., they look at something called poverty level, and it works in the percentage of their federal poverty level is how it's defined. And when you look at less than 100%, that is the most poor people in the U.S. versus 200% or higher. That means less poor. And if we look at those characteristics as well, we see that women who were in the less than 100% were also drinking quite heavily in pregnancy, and they had the highest proportion there. Health insurance in the U.S. was also a factor, and it probably correlates in the U.S. with poverty levels, since those who are in the less than 100% category will also qualify for Medicaid. So not surprisingly, that 3.7% of women who were pregnant were also likely to be on Medicaid if they were binge drinking. And as we mentioned before, if we look at trimester of pregnancy, we see that during pregnancy in the U.S. as well, the binge alcohol use percentages decreased over time from the first trimester, 12.8% to 0.8% to 1.0% by the third trimester. So some very telling data in terms of the kind of characteristics that could be associated with continued alcohol use in pregnancy. They also did the same analysis for tobacco use, and they looked at past month tobacco use products, past month cigarette use, and past month daily cigarette use. So if we want to look at the daily cigarette use, because this is a category that we think will have more harm in pregnancy, same categories of age group, poverty level, health insurance, and the trimesters. So if we look at the pregnant populations, again, the higher rate of use is among those women who are between 18 to 25. When we look at poverty level, again, less than 100%, 18.2 of them that were pregnant were smoking daily. Similarly, 14.5% of the Medicaid group were also smoking daily. And it was nice to see the decline of 11% to 7% the second trimester, and there seemed to be an increase in the third trimester, which makes me wonder about also reasons for smoking in pregnancy. Is that related to anxiety as delivery is approaching? So we're seeing some very similar trends between alcohol use and tobacco use in pregnancy, and it's alluding also to the thought of concurrent substance use during pregnancy. So what are the factors that could predict both? So this is data from Australia. It was part of the Australian longitudinal study on women's health. So the Powers and al. Wanted to look at factors that could predict what are the chances that someone was going to reduce concurrent drinking and smoking in pregnancy. So actually one of their conclusions was more about what are the factors that predicted lower reduction in concurrent drinking and smoking. So what they found is, again, similar to the data in North America. They found those women who had more disadvantages, and this was defined as lower education level and more financial stressors, lower levels of support, so maybe single, less partnered. Those with poor mental health and having a history of partner violence were less likely to be able to decrease their concurrent drinking and smoking in pregnancy. The other category, women that they also found were less likely to make changes, were women who were deemed to be heavier smokers and women who were pregnant but had other children at home. So it's the second or third time pregnant women who may have false confidence from what they deemed good outcomes the first time around, they're less likely to make a change the second or third time around. So this leads us to look at not just smoking and alcohol use in isolation, but to really realize it's a cluster of risks. So as I mentioned, we're not just looking at one substance, it's usually polysubstance use. So women who may be drinking may also be smoking and also may be using other substances. There's also higher rates of those social stressors that I pointed out. So they typically have lower education, lower income households, and they have also a lack of social supports. And there's also the mental health component. So what that means in our assessment, we have to look at these various overlapping circles, but then we also have to take that information and put it into our management plans. We have to consider the context of their use when we're dealing with women who may fit the criteria for a substance use disorder. So the impact of concurrent use has multiple areas to look at. First of all, we know that alcohol and smoking have this dose response where we know that women who are heavier smokers also tend to be heavier drinkers. We know one leads to the other and vice versa. We also have evidence that there can be some exacerbation in effects when the two are used together. So there is evidence looking at outcomes of infants who were exposed to both alcohol and smoking in pregnancy, and the evidence is pointing to reduced birth weight for these infants. So there is an exacerbated effect on intrauterine growth restriction with the use of both substances. Interestingly, when we look at concurrent quitting, someone who is able to quit tobacco use may be more likely to be able to quit alcohol use as well, and vice versa. So we have this impact in terms of affecting use, but it can also help when it comes to looking at abstinence in pregnancy. So why do we care about women who are drinking and smoking in pregnancy? Well, we know that alcohol use and cigarette smoking during pregnancy and breastfeeding are associated with numerous negative consequences, both for mom and infant and child. They're actually modifiable risk factors that can affect pregnancy, and we can make a difference before pregnancy or in early pregnancy. We can improve outcomes, so stopping at any point alcohol, tobacco use can make a positive outcome. We also know there's evidence for effective interventions to assist women who are smoking and drinking and during lactation, and that's why we want to implement these interventions as early as possible. So I've alluded to some of the effects of alcohol and tobacco, so we'll go through the different categories. When it comes to maternal health, we've talked about some of those clusters of risk, including not just medical effects, but it can also go on to psychiatric effects and domestic violence. So I'm going to focus more on the pregnancy health, the neonatal and childhood effects in the next few slides. So when we look at the evidence, there's been numerous systematic reviews that have found a dose-response relationship between smoking and negative pregnancy outcomes. This means that the more a woman may be smoking during her pregnancy, the more likely these effects are to be happening. So there is a two-time increase in the relative risk of having a spontaneous abortion, which is miscarriage, ectopic pregnancy, intrauterine growth restrictions, premature delivery, premature rupture of membranes, and placenta complications in a woman who's smoking during pregnancy. And as a result of these complications, there's also been an increase of 30% in infant mortality. So the infants are more likely to die because of issues related to premature delivery, to being smaller at birth, and as well from placental complications, so placental previa, placental abruptions. So all of these can have an impact on the infant in the first 28 days of life. Infant morbidity, which is also a big concern, refers to the fact that if they are born more premature, they're also more likely to need NSDUH admissions, and this is also increased in this patient population. There's also effects documented from secondhand smoke exposure, and similarly, there's evidence from systematic reviews, meta-analyses, and these have found that there's negative perinatal outcomes associated with secondhand smoke exposure. So these babies tend to be smaller, so up to 60 grams smaller at birth. There's an increased risk of also being deemed low for birth weight. They also tend to have smaller heads, but they seem to have longer lengths, or birth lengths. There's also been some associations with congenital anomalies, and this is a myriad of findings. This is a bit controversial, and the odds ratio is close to 1, which means that's probably not a 100% confirmed effect. And there's also that increased risk of perinatal mortality that I mentioned earlier, because with secondhand smoke exposure, you can also have an increased risk of SIDS as well, and this is what this is referring to. So in women, in pregnant women, we don't just worry about the effect of mom smoking, but what about all the people in the household who may be smoking around her and the negative effects from that? We know in childhood, there's also ongoing effects from maternal exposure during pregnancy and secondhand smoke. So these babies tend to be more cranky or colicky. As I mentioned again, sudden infant death syndrome, 2 to 5 times increased rate. There's also more respiratory illnesses in these children. They have more incidence of bronchitis, pneumonia. We know there's definitely a link with asthma, allergies, and a significant increase with the mom who's smoking during pregnancy and postpartum. There's increased risk of middle ear infections, and there's also been associations with what's called neurodevelopmental effects and behavioral problems. The evidence is not as strong, but there is some link with poor math, reading skills, attention deficit, and hyperactivity disorder. So it is a concern in women who may be smoking, particularly at high levels during pregnancy and in the postpartum period. In breastfeeding, we know that nicotine is excreted in the breast milk, and these products are then concentrated in the breast milk, and it could be up to 5 times greater than it's concentrated in maternal blood. There's evidence that smoking can decrease the quality and the quantity of breast milk by inhibiting milk letdown, and therefore this can lead to feeding difficulties. There's also evidence linking smoking and during breastfeeding to earlier weaning from breastfeeding, and probably that's related to the decreased milk supply. Because breastfeeding is so protective, the recommendations for most societies is that we still encourage breastfeeding among smokers, but we definitely don't want these women to be reducing their use or trying to time their cigarette smoking around breastfeeding, which is a little bit more cumbersome. So one recommendation is to look at how long it takes for the nicotine to be removed from breast milk. So the half-life of nicotine is 95 minutes. So therefore, there is a recommendation to look that women should avoid smoking just before the start of a feed or during feeding, and to wait until the feed is completed so that the levels of nicotine in the breast milk will be a lot less by the time that that feed is initiated. What about alcohol use? So there's numerous pregnancy effects with alcohol use during pregnancy as well. We have increased risk of spontaneous abortion or miscarriage, premature delivery, intrauterine growth restrictions, again leading to low birth weight, and even stillbirth with the use of alcohol in pregnancy. I wanted to point out a new guideline that was published in 2017, and this is looking at a new way of addressing fetal alcohol spectrum disorder and how to define this disorder. So originally, this was deemed to be an umbrella terminology that was going to encompass a variety of effects from alcohol use in pregnancy. The new guideline is pushing for this to be the new diagnostic term, and this is now to be describing the effects of prenatal alcohol exposure. And the diagnosis of FASD is now proposed to be based on two things: the presence of the sentinel facial features, and then also the presence of neurodevelopmental domain abnormalities. And there's specific domains of the brain and functioning of the brain that were deemed related directly to alcohol exposure. They actually took out the criteria of birth because they didn't find that was consistent. And so the new proposal then is for children to be diagnosed as having FASD. With the criteria would be deemed for diagnosis would be if they have FASD with sentinel features. If they don't have those sentinel facial features, if they have impairment in 3 or more neurodevelopmental domains, then they would also meet criteria for FASD. They've also proposed having a category of add risk for neurodevelopmental disorders, meaning that they didn't meet the full criteria, but there's some indication of neurodevelopmental disorders or concerns. I don't know how much of this new guideline has been adopted, but I thought I would point it out. It was published by some of the similar authors that had published the previous one in 2005. And again, with this new literature and this new push to redefine FASD, may be helpful to have this information. Now, the prevalence of FASD is quite interesting depending what studies you're looking at. The prevalence is really variable. I've seen various numbers quoted in various publications from anywhere from 1 in 1,000, 3 in 1,000, 5 in 1,000. There's various rates, again, depending on the extent of the exposures. There's also suggested prevalence rate of FAS of 30 to 40% in women who are heavy drinkers. So we know FAS and FASD is not something that occurs in 100% of exposed infants, but it is the most concerning tragedic effect of alcohol. And these are lifelong impairments in their brain that we cannot reverse. So what are the effects for someone who may be also using alcohol while they're breastfeeding? I was actually surprised about how little evidence we have about the effects of alcohol during breastfeeding. So first of all, we know that alcohol, when it's consumed, flows freely into breast milk, and so it's detected within 30 to 60 minutes of maternal ingestion. This effect may last up to 2 to 3 hours after one drink alone, and so we know that if someone were to breastfeed within that time period, they would get the infant would have a high exposure to alcohol content in the breast milk. There's some evidence as well that heavier alcohol use may affect milk letdown and reflux, and therefore that this may also affect the duration of breastfeeding because of the alcohol use. There's also some evidence that alcohol in breast milk may affect infant sleep, so these babies had shorter sleep cycles after feeding, and there was one study that alluded to some gross motor developmental delays in infants who were exposed to alcohol use during lactation. We don't have tons of evidence in the field, but I think at this point in time it's safer to avoid drinking during breastfeeding because of these possible outcomes and because it may be teratogenic in addition to what was already exposed to in utero. I wanted to highlight some of the general principles for working with pregnant women. I think it's important that when we look at someone who may be having a substance use disorder in pregnancy, we have to be very aware that first of all we have to engage them in care. That means we have to engage them in discussions. And if we have someone that we're going to scare away by providing a message that may be very fearful for them, they may never come back to get more help. So I would say the first general principle is to look at using a woman-centered approach. So what that means is using the context of her life to understand her alcohol use. So what are the needs in her life, and what is the role of alcohol with respect to that context of her life? Harm reduction. So instead of looking at just abstinence, reducing the negative consequences of use. So we have a lot of dose-response effects with alcohol and tobacco use in pregnancy. So looking beyond abstinence, but also reduced use. We also look at integrated and comprehensive care. So what that means is that we have to offer a range of services and be aware of a range of services, because not everybody needs the same level of intervention. It really depends on their level of use. And we have to offer that continuity of care, and this again has to be across a variety of interventions. So I think we have to keep this in mind before we get to the messages that we're going to provide to the woman that presents in your office. Pregnancy is also deemed that window of opportunity, so it's a teachable moment. And we have evidence from this, from one study that looked at providing brief interventions with pregnant women. This study looked at 255 pregnant women that were attending a public health nutrition program in California. And these women were randomized to an assessment group, and then some of them were also provided a brief intervention. So in the assessment group, they took current drinkers who had a comprehensive assessment, and they were just advised to stop drinking during pregnancy, and they got no additional help. In the brief intervention group, they took the current drinkers, and they were provided also some ongoing brief intervention and a workbook that also helped to guide them in this work. So not surprisingly, in both groups, there was a decrease in alcohol use, a substantial decrease, but the women in the brief intervention group were actually reducing their alcohol use 5 times more than the women in the assessment-only group. So what this is showing us is that women who are pregnant are receptive to the message, so that teachable moment. And so we have to use pregnancy as an opportunity to help them maybe make a change that they couldn't do before. So here is a general approach that I would suggest when dealing with pregnant women with respect to alcohol and tobacco use. This is a public health approach that's been deemed effective. Numerous organizations in the U.S., like the U.S. Preventer Task Force, the American Society of Obstetricians and Gynecologists, all endorse this approach to dealing with women. So starting with screening, followed by brief intervention, and then referral to treatment. And I put underneath the 5 A's model to parallel what those 3 strategies include. So screening is the ask, brief interventions, assessing and advising, and then referring to treatment, so assisting and arranging for specialty services as deemed necessary. And there is evidence that this approach actually is effective in pregnancy to reduce both alcohol and tobacco use, and I will provide you that evidence. So let's start with screening. So a couple of key points here. We're looking at universal screening. So the recommendations is to screen all pregnant women. So not just use the risk factors or some of the characteristics I mentioned before, because then we may miss cases, and that also ends up perpetuating those myths we have or stigma of certain populations being more likely to be smokers or drinking in pregnancy. So we want to give the chance for all pregnant women to be screened. So asking about alcohol use, so very straightforward. Do you ever use alcohol? When was your last drink? The second question, in the past year, how many times have you drunk more than 4 alcoholic drinks per day? I think it's important to screen for binge drinking. That's what the intention of that question is. So we don't just want to know if they're drinking at low levels, but have there been binge episodes, because binge drinking can be concerning. And when we ask about tobacco use, do you smoke? Does anyone smoke around you? Is to look at the secondhand smoke exposures. So the goal is to screen maybe at the first visit with the patient, and then to keep asking throughout the pregnancy, maybe in each trimester, and to keep rescreening if there seems to be an ongoing risk. Now, based on those answers, we would develop this risk assessment categories. And the pyramid at the top shows you how there's many more women who are in the low risk category and very few who are in that high risk. So the low risk pregnant women would be those who have no current use, or maybe the ones that stopped once they were aware they were pregnant. There is the moderate risk category of women who have continued low level of use, or the ones who end up stopping in later pregnancy. And there's also a category of high risk. So these are the women who probably meet criteria for alcohol and nicotine use disorder. So when we look at the intervention, so after screening, brief intervention should really be offered to all the category of women. And then the referral to treatment is a subcategory. So the high-risk women are the ones who are more likely to benefit from that intervention. And this has been from a paper endorsed by the U.S. Preventive Task Force, where they convened a whole bunch of experts, and they found this approach would be the most evidence-based approach to dealing with this population. So who are those women in the lowest category? So who's more likely to quit? So it may not be surprising that the spontaneous quitters are those women who may be higher educated, who may be lighter smokers, or maybe who were drinking, occasionally, those who live with non-smokers, non-drinkers, those who have stronger beliefs in the harms of smoking and drinking during pregnancy, and those who are experiencing their first pregnancy because they're most likely to be concerned about the effects of use in pregnancy. So what about brief intervention? So brief intervention refers to really brief counseling or brief advice-giving sessions. These are 5 to 20-minute discussions that can be delivered by a range of practitioners, and there's evidence about a variety of practitioners providing brief interventions. Some of the studies included partners, and some of the studies looked at providing written handouts or quit guides, also including these patient-focused guides to quitting. And in the end, what the essence of brief intervention is to use cognitive, motivational, and supportive therapies to help women to quit or to prevent relapse among those who have already spontaneously quit. So these can be done in a very simple way. So what are the tasks of brief interventions? So first of all, we're going to be using motivational interviewing techniques to achieve these tasks. So the first task is to raise the subject of use in pregnancy or lactation and to provide feedback. So the specifics are to actually advise absence or reduction in use if absence is not possible. So an example there is, as your provider, I recommend that you stop drinking or smoking. And then you can provide the rationale for that. Another task is to enhance motivation. So if someone says, I cannot see myself quitting, then asking or understanding what the motivation for use is. How can they replace what they're doing now with something that's healthier? And then finding that hook, that one reason that may help them make a change. And obviously, negotiating a plan. So it's more helpful if the patient determines the goal of their plan than it's for us to devise that goal for them. So I usually ask my patients, what would you like to see happening for the rest of your pregnancy? Which is really getting to the crux of what her plans are. I also offer close follow-up, and it's recommended that they can be seen every 1 to 2 weeks, depending on their risk category. So one way to address this is to ask, would you like to come back in 1 to 2 weeks to have another discussion about this? Would that be helpful? So again, making it optional for her to know that you're there to have these ongoing discussions. And what we're looking at is to have maybe more than one of these opportunities to have discussions about their alcohol use, their cigarette smoking, and how we can help to intervene for them. So what is the evidence for brief interventions? So this is from a Cochrane database of systematic reviews that was published in 2017. There were numerous iterations of this, but this is the most latest evidence that was published. So I've summarized the information from the Cochrane review in this table. So there were 102 randomized controlled trials that they found for this systematic review. When they broke it down by various subcategories, 54 of these studies looked at counseling, 12 looked at health education, 6 looked at feedback in conjunction with counseling, 13 looked at incentives, so contingency management, 7 looked at social support, and 1 looked at exercise. So the outcomes that they were looking at were the number of pregnant women who were stopping smoking in later pregnancy, and then they looked at a bunch of neonatal outcomes. They looked at the mean infant birth weight, they looked at the number of low birth weight infants, and admission to the neonatal intensive care after birth. So what they found is that there is moderate to high evidence that counseling, feedback that was associated with counseling, and incentives were more effective than usual care to reduce the number of women who were smoking in late pregnancy and also improving neonatal outcomes. So the actual numbers are shown in the last column there under results. So 35% of women stopped smoking in late pregnancy with these interventions. The mean birth weight was increased by 56 grams on average. There was 17% fewer infants born with low birth weight, and there was 22% reduction in admissions to NICUs after birth. So it shows you the power of brief interventions in motivating pregnant women to stop smoking in pregnancy. There was no effect seen in terms of benefit in reducing preterm births or stillbirths, and obviously there's no adverse effects noted from any counseling interventions. So because of the quality of the evidence we have with brief interventions for smoking cessation in pregnancy, this would be deemed the first-line intervention with pregnant women. What about dealing with alcohol use in pregnancy? There's actually less robust evidence. So the Concurrent review that looks specifically at brief interventions for alcohol use in pregnancy only found 4 randomized controlled trials. These also consisted of educational and counseling interventions, and they had a total of 715 pregnant women involved in these studies. Their outcome was very specific. It was absence or reduction of alcohol use to less than 7 standard drinks a week during pregnancy. Now, they used this outcome because they deemed that less than 1 drink a day was the sort of threshold they had seen some harm with in pregnancy. Not surprisingly, these studies all were done very differently. There was not consistency in results among the studies, and only 2 out of the 4 studies actually found a positive effect. So based on this review, it was deemed that there's limited evidence to suggest that psychological and educational interventions may result in increased abstinence from alcohol or a reduction in alcohol consumption by pregnant women. And there was very little evidence that these interventions improve maternal or infant health. So a little bit of promising information that brief interventions can be used for alcohol use in pregnancy. So another researcher went beyond the Cochrane review, and they looked to find additional studies. So they published a review, and they found 8 studies. The 6 were RCTs and 2 were non-randomized. And in these studies, there was a range of interventions used. There were single or multi-session face-to-face brief interventions, and they also provided take-home manuals or included partners, and 2 of these studies were deemed to be of good quality. Their outcomes that they were addressing in these studies were maternal alcohol use during pregnancy. So these studies actually found that there was some evidence for even a single face-to-face brief intervention in terms of increasing abstinence from alcohol use during pregnancy. So 1 session of advising someone to quit drinking in pregnancy about the effects of alcohol use in pregnancy has been deemed effective. Most of the evidence was from multi-session brief interventions in reducing alcohol use in pregnancy. So again, this goes back to that idea of you have to engage these women in discussions, and they have to come back for you to have a bigger impact. So the conclusions from this systematic review is that there's limited evidence for the single session face-to-face, but more evidence for the intensive brief interventions for reducing alcohol use in pregnancy. Interestingly, the studies that also included the partner or the women that were heavier drinkers had more benefit from attending for these brief interventions. So I wanted to summarize what should be some of the key messages that would be delivered as part of these brief interventions. So we know this is a modality that works with pregnant women, but what should we be telling them? So there's educational components to brief intervention. So we should be emphasizing that there's no safe limit of alcohol use or smoking during pregnancy or lactation. There's no safe time period. There's no safe amount. We also know that alcohol and smoking is associated with negative health outcomes for mom and baby, and this is the reason why we recommend abstinence. And so if they're not able to be abstinent because of the dose-response effects, we also would recommend reduced use because this would be beneficial as well. And quitting at any point, reducing at any point in the pregnancy is helpful. So that's why I want to summarize what we should be saying, what should be the messages provided to women. There's also important information around advice to eliminate secondhand smoke exposure, so we should also make sure that we recommend a smoke-free home environment for all pregnant and breastfeeding women. We should encourage that the women should be smoking outside of the home. There should be no smoke in their car even when they're driving, and they should be leaving the area when someone's smoking around them and attending smoke-free places. I would say with the legislation in Canada now, it's very much less likely to have exposure in restaurants, but there's still lots of places where women may be receiving secondhand smoke. So who should be referred to treatment? So women who are not able to reduce or abstain from alcohol use or smoking despite brief interventions may benefit from referral to specialty treatments. And those women who meet criteria for substance use disorder, so specifically alcohol use disorder, nicotine use disorder, may benefit from referral to a specialty service. Again, depends on the community availability. I did want to also highlight some of the evidence around pharmacological management. And the reason for this is that some of the evidence that we have in pregnancy is limited, but we do have some evidence for nicotine replacement therapies that I'm going to review because this is an over-the-counter product that could be used. So the three mainstays of treatment for smoking cessation still are nicotine replacement therapies, Bupropion, and Varenicline. I do want to highlight that a lot of the e-cigarettes are starting to be more popular in the general population, and also the fact that we have no evidence around the safety of e-cigarettes in pregnancy, and there's really no data that these are more effective than the other strategies we have currently for smoking cessation. So at the present time, there's no safety, there's no recommendation to replace smoking with e-cigarettes during pregnancy or lactation. I do want to highlight that nicotine metabolism is changed in pregnancy by a variety of mechanisms. So what we know is that because of the induction of one of the liver enzymes, there is an increased metabolism of both nicotine and its metabolite cotinine in pregnancy. What that means is that there's also a shorter half-life of these products. So nicotine's half-life is decreased by half, and so is cotinine. So what that translates into is that for a given amount of exposure, there's going to be less effect on the fetus, which is good news. However, when you're looking at nicotine replacement therapy, they may actually need higher doses of products to maintain the same levels of nicotine. And this is why maybe they're going to be starting to have more nicotine withdrawal as they're progressing in pregnancy because the same cigarette is not giving the same benefit anymore. And in some cases where cotinine is used as a marker of smoking cessation, of smoking in pregnancy, cotinine doesn't become a reliable marker anymore in pregnancy because it is being cleared so much faster. So what is the evidence for the use of pharmacological interventions for smoking cessation during pregnancy? Well, we have very little literature, and this is one of the data systematic reviews out there, again, from the Cochrane databases. So they tried to find information on all of those variety of pharmacological products. In the end, they were only able to find 9 randomized controlled trials that included 2,200 women. Not surprisingly, 8 of these studies were related to nicotine replacement therapy, and 1 was related to Bupropion. The evidence only focused on smoking cessation for pregnant women, and in the second box it highlights that we don't have any evidence at the present time which looked at the benefits of using NRT or Bupropion for improving birth outcomes. So what is the evidence around nicotine replacement therapy? There were 8 studies to date. 1 used nicotine gum, so low level 2 milligrams. There were 6 using nicotine patches, and 1 which gave the participants a choice of patch, gum, or lozenge. Most of the studies actually were using these moderate strength patches only, so they were using the 15 milligrams patches, and they were using them only for a 16-hour duration. So that they were actually reducing the amount of nicotine exposure in pregnancy. So what the results show is that there was a borderline significant benefit from nicotine replacement therapy in addition to behavioral support for pregnant women for achieving abstinence in late pregnancy. There was no impact on birth outcomes, and there was no negative effects from using these in pregnancy. So at the present time, we have some weak evidence for the effectiveness of nicotine replacement therapy for smoking cessation in pregnancy. So what this means is that for women who you've used brief interventions, if you find that you need to add something on, nicotine replacement therapy can be deemed as a second-line approach in addition to the counseling you provided. So the recommendations from a variety of organizations usually state that nicotine replacement therapy during pregnancy can be used in conjunction with counseling. They recommend intermittent dosing NRT because of the studies that we have to date that did not emphasize the 24-hour use of patches. And at the present time, there's no studies looking at NRT use during lactation. But I would say if there is some weak evidence during pregnancy, that we probably would see some similar effects during lactation. What about Bupropion? So we only have 1 study addressing the use of Bupropion in pregnancy. Interestingly, the Cochrane review decided not to actually comment on the use of Bupropion in pregnancy because there's such little evidence. If we look at the 1 study, there was no harm associated with using it in pregnancy, but there was some benefit, some increased quitting rates with its use in that pregnancy population. So I think when we look at Bupropion, we would consider using it maybe as a 3rd line because of the lack of evidence about its effectiveness. So it would be something you can consider in someone who may have a history of depression and wants to quit smoking. It may be deemed acceptable in that patient population. Varenicline, so Champix, there is no evidence of its use in pregnancy. There's been no human studies. There's some evidence from animal studies which didn't show any teratogenic effects. So at this point in time, we cannot be recommended for the use of varenicline during pregnancy or lactation. And I do want to comment on pharmacotherapy for alcohol use disorders because we do have 3 general medications that would be used for this, for achieving abstinence. So we have disulfiram, acamprosate, and naltrexone. So not surprisingly, the Cochrane review they attempted to do didn't find any randomized controlled trials included in this review. So they couldn't make any recommendations. What I would say is at the present time, if you look at the 2 aspects of effectiveness and safety, we have very little data on the safety of using any of these medications in pregnancy. So I'm going to go back to the list. So if we look at disulfiram, acamprosate, and naltrexone, there is only some case reports reported around the use of these in pregnancy. With naltrexone, there's only animal data. There's no human reports. There was also with naltrexone some concerns around changes in the brain receptors. So are these infants going to be more sensitive to certain pain medications or to pain later on because of the exposure in pregnancy? So we do not have any rigorous trials saying that using these in pregnancy. But then we have to balance out the risk of exposure to alcohol in pregnancy. So there is, I would say, some centers that would recommend the use of a medication like naltrexone in pregnancy if someone's continuing to drink at a heavy amount, because the risk and benefit analysis there may be in favor of using the medication to achieve abstinence. So again, we have to be very careful on the use of these medications because we don't have the data. We don't have safety data, and there's definitely no efficacy data. So we don't even know if they're safe to be used. So then to summarize, alcohol use and smoking are highly prevalent during pregnancy and lactation. There's universal screening for alcohol use and smoking recommended. Brief interventions should be offered to all pregnant women and all breastfeeding women. This should be usually consisting at least of 1 brief single intervention, and for some women this may be multiple repeated interventions. Referral to treatment pharmacotherapy may be indicated in a small number of cases. And I wanted just to point out some of the other guidelines that I have used for putting together these recommendations from the World Health Organization. They have several guidelines looking at management of substance use disorders in pregnancy, specifically this guideline on tobacco use, secondhand smoke exposure in pregnancy. There's the Canada DAB guideline, the SOGC guideline, and also there's a toolkit from Health Canada. And then for patients, there is also the Canadian Cancer Society Smokers Helpline. So there is counselors who've been trained to deal with pregnant women who are calling in needing help to quit smoking. They're trained. They can advise your patients. So this could be a phone number they can reach out for help as well. And I've also summarized all the systematic reviews and the key articles that I've also used to put together this presentation. And I'll stop there and take any questions.
Hi, Dr. Ordean. Great presentation. So wonderful. I just am seeing a few questions in the chat box. If you want, I can scroll and read them for you, or you can scroll yourself and pick which ones you would like to address first.
So I'll look through the chat box. So one of the questions is, do you include vaping, nicotine as well, or anything smoked? You can definitely, when someone's saying yes to smoking, you can then get into the details of what tobacco product they're using and how they're using it. Like I said, when we're looking at really the prevalence data, the vast majority, so as we saw in data from Canada and the U.S., 90% plus women are actually smoking cigarettes, but you can definitely get into the more specifics. There's a question about heavier drinking women attending with a partner more likely to abstain. Absolutely, if they're living or if they're with a partner who's also using alcohol or smoking, not including that partner in intervention, sometimes the intervention you're providing to the pregnant patient may not be as effective. So it depends on your comfort level when including a partner or whichever organization you're working with. If you have someone else that could also work with the partner, it would be helpful to increase the chance that that woman would be abstinent during pregnancy and postpartum as well. Someone was asking about a supplement named Crave. I'm not sure what that refers to. I've been looking a lot at the information in smoking and alcohol in the last couple of days. I haven't come across that. I'm not sure who that's from. If you want to provide me some more details, I can look it up further for you. And then I can't really comment beyond that. So would I recommend lozenges, gum versus inhaler sprays as a PRN? I usually, when I look at the short-acting products, I actually bring up one of the manufacturer websites to show patients what these products look like. Or if you have a brochure in the office, it's even more helpful to show them what these products look like. In my experience, some patients have tried, for example, nicotine gum in the past. I usually explore, did that work for them? What did they not like about the product? I look to see, what is it that they're looking for as a PRN. There's also some patients who have this hand-to-mouth fixation or this habit. So then for them, maybe then an inhaler makes more sense because then they can have something in their hand. So it's really working with the patient which kind of the nicotine replacement therapies may be appropriate for them based on past experiences and what they seem to be more keen on using themselves. So someone was asking about extending it to smoking marijuana during pregnancy. I'm happy to comment on that, but that's a totally different body of evidence. And I'm going to abstain from saying too much, except that the recommendation is if someone's using tobacco and if they're also smoking marijuana use, depending how that's linked, I would actually work on reducing both. Because I have patients who are mixing the two substances together in their joints. So I usually ask them how they prepare it. But really the recommendation is because of the concerns around marijuana use in pregnancy as well, if it's related, they should be looking at abstinence from both substances. And I think the key message should be absolutely no alcohol while breastfeeding because we know alcohol gets in the breast milk. I mean, if someone's going to an event or maybe a one-off drink, you can guide them on saying it may take 2 to 3 hours for that alcohol to be metabolized and to get out of their system, that while it's present in their blood, it's also going to be present in their breast milk. So if they want, they can keep pumping, dumping the milk to relieve themselves so they don't get too engorged. If they're concerned about exposing their infant to that breast milk with alcohol in it, but it wouldn't be something I would recommend on an ongoing basis for someone to try and either pump and dump or for them to try and time their alcohol use to breastfeeding. Their general recommendations should be that there should be no alcohol use while breastfeeding. Okay, so someone just expanded. The crave is related to cytosine. So I know cytosine is a newer supplement, and I know Dr. Selby has presented on that before, but I have not seen any information on its use in pregnancy. I'm happy to review it and then provide like a feedback afterwards as an add-on to my presentation. Unfortunately, someone pointed out that the manufacturers of short-acting nicotine replacement therapies do state that they're not to be used in pregnancy. I think that's really more of a liability issue for the manufacturer because in some ways nicotine replacement therapies have not been actually officially approved for use in pregnancy. And that's why in my disclosures I am stating that I am recommending they use a product which are not officially approved in pregnancy. But if we look at what the evidence is showing, there's no harm with using them in pregnancy. We're eliminating thousands of chemicals present in cigarette smoking. So then again, looking at that benefit-risk analysis when we're looking at pregnant women and women who are breastfeeding, it would be better for them to try nicotine replacement therapies instead of continuing to smoke during any of those time periods. And that's the same analogy I was using with any of the medications such as Revia or naltrexone used in pregnancy. There are some specialty treatment centers like ours at St. Joe's. We are starting to look at using medications like Revia, but it is a case-by-case basis. It is with discussion with the patient, acknowledging our lack of safety data, our lack of efficacy data, but exploring the risk-benefit. So someone who's drinking quite heavily and who's drinking daily probably has a lot more benefit from using a medication. So this is why it's a little bit more challenging in pregnancy because a lot of the therapies we're using, pharmacological therapies, will never get them probably officially approved in pregnancy, and this is where we have some evidence around benefit and no harm associated with it. We're going to make those recommendations. So absolutely, depending on the level, so I didn't go into the details of the NRT, how to use them. If someone is smoking generally more than 1 pack a day or more than half a pack a day, probably the short-acting nicotine products may not be as effective for them. So for that woman, I would recommend starting with at least a 7 milligram nicotine patch and then using the short-actings as PRN. If someone's smoking a pack a day during pregnancy, I would definitely start with the higher dose patch and then wean them down over time. So someone wanted to know about my recommendations for the 2 case studies. So for the first case study, that would be somebody who probably, if you're giving the advice about quitting in pregnancy is the safest approach because she's smoking 5 to 7 cigarettes for the past 3 years, she may be able to quit on her own. And with some feedback again, she may be someone who may need to use some short-term nicotine replacement therapies, but I would anticipate that somebody with simple advice with a few sessions may become one of those spontaneous quitters. What about the second case scenario? So I would actually ask her next how soon she smokes after getting up. So I would actually look at the level of nicotine dependence with someone who's smoking a pack a day. So a pack a day for 15 years, I would have a hunch this is someone who's nicotine dependent, and probably she's going to smoke at the latest within 20 minutes, half an hour waking up. So this is a woman that I know quitting on her own is likely not going to be effective. She's going to be one of those women that I would have to recommend nicotine replacement therapies to, probably starting with the patch, as I mentioned, adding on maybe even short actings, and then weaning her down. With respect to the binge drinking in that case scenario, I would actually look to see how the binge drinking relates to her smoking, advise abstinence, look to see what are the factors that contribute to her binge drinking on the weekends. What is that about? Is this her party lifestyle? Is this an unplanned pregnancy? What's the social situation like? So that may be a little bit more challenging to treat, and she may be having a harder time being absent from alcohol use and from her cigarette smoking. So that would be a patient that may need multiple sessions, brief intervention sessions. That may be someone also to link up to more specialty services. So there's some recommendation. There's a question about NRT in first trimester. I don't see an issue with using NRT at any point in the pregnancy. If someone's smoking in the first trimester, the risk of harm from cigarette smoking is probably greater than her using nicotine replacement therapy in that first trimester. Because again, we're eliminating all those other chemicals in the cigarette. If we're looking at what is the concern in smoking, it's not just the nicotine, but it's the carbon monoxide. So if you're just looking at using nicotine replacement products, you're really eliminating a lot of risk.
Okay, that looks like it's it for questions. Thank you so much, Dr. Ordean. That was a very educational and informative webinar. And thank you to everyone who attended. The chat box was very engaging, and lots of great questions were being asked, so thank you. This webinar has been recorded, and I will be distributing a link to the recording as well as the slides, so you can share it with your colleagues. Remember, a link to the post-learning assessment and evaluation will be distributed this afternoon, and you will have 1 week to complete it if you would like a letter of completion. And if you participated as a group, please make sure that you email teach@cmh.ca with a complete list of participants by 2 p.m. And work is currently being underway to bring you a webinar in October, but as of current, our next scheduled Teach Educational Rounds is not until November, where we'll have a stop showcase of the evolution of the Hamilton Public Health Quit Smoking Clinic from 2008 to 2019, and that will be presented on November 6th, and registration will open soon, so you can look forward to that. And again, if you have missed today's presentation, you are interested in viewing it again, or you are interested in viewing previous webinars, a list of our archived webinars can be found on our website, so you can view them there. Thank you, everyone. Have a great week.